Please join me in welcoming Dr. Ashraf to the stage.
السلام عليكم. مساكم الله بالخير جميعا. It's very wonderful to stand in a platform that talks about patient safety. We used to talk about quality for the last 25 years now, as far as I can remember. I'm not older than this. But 15 years ago, quality and safety concepts were strangers in healthcare setting. And today, I was discussing with Dr. Ali that the attendance is really marvelous. And it shows, despite all the difficulties, despite to the crowd, we really have very good attendance, very good attention to the patient safety. So today we're discussing diagnostic errors, and I'm sure that you've heard about diagnostic errors in other settings, and I'm discussing diagnostic errors in primary healthcare. Let's assume that 1 in 1,000 patients, and this is only an assumption, 1 in 1,000 patients will suffer a diagnostic error. That's 0.1% only. However, for that patient, the diagnostic error was 100% because he suffered from the error. That patient wouldn't care about the numbers that we display in research. That 0.1% is 100% for the patient. That patient could be you, or could be me, or could be somebody whom we loved or take care of. Diagnostic errors is much bigger than the percentage that I have just assumed now. I remember one of my teachers once told me that medicine is a science of uncertainty and an art of probability. And he said in medicine, we do good, but we also do harm. The problem is, we're not sure today if we're doing more good than harm or more harm than good. And I mean it. We're not sure. We're very arrogant. We think we have the best advanced technologies in medicine, but we're not sure. As simple as ensuring safety is something that we're not sure of. So today, focusing on primary care. Why are we focusing on primary care? Access, whether, by the way, too much access or little access or weak access, is an issue in primary care. When primary care is very much accessible, then you see a lot of patients. And when you see a lot of patients, then you can't really spend enough time with patients. But also, access is an issue. Not every patient, not every person in the community can access care, primary health care specifically. In Riyadh, you can see primary care center every 2 blocks. You go to a remote area, you can't access primary care. Some people need to travel for hours to access a primary care. If you don't access a primary care, then diagnostic error increases because you get delayed. You don't go for follow-up appointments. So access is an issue. Primary care is the first contact. And so people come to us once they feel that there's something is wrong. However, when they come for the first time, we're not sure. They are not sure what's wrong. We're not sure what's wrong. It's not yet developing. It's not yet differentiating. In primary care, the resources are limited. And we say resources, it's not only the human capital, it's not only the diagnostic test, it's also the time. You don't have enough time to spend with the patient. Somebody is following you. They want you to finish the patient within 10 minutes, and that increases also diagnostic errors. Patient volume, of course, we talked about that. The day before yesterday, I was traveling from Dammam to Riyadh. I stopped in a petrol station, and I needed a coffee, so I lined up in the drive-through coffee shop, and then there was somebody who was coming in the wrong way, and he He just blocked the way. So I said, hey, can you please move? He said, you know, it's crowded. Where do I go? Where can I go? In the crowd. And he seemed to be a very simple person, by the way. He said, in the crowd, you really need to be tolerant. I said, yeah, you're right. Thank you very much for telling me that. He said, let's take an example of a family physician. He sees a lot of patients. And I said, what? And I was thinking, where is the chance that someone, a stranger out there in the desert, see you and give you an example of a family physician? And I thought, I don't know. Does he know something about me? Is he an intelligence, sort of? So I said, why did you give me the example of primary care? He said, no, because family physicians see a lot of patients. Everybody knows that. Oh, I said, okay, it's good to know that everybody knows that. I said, are you a family physician? He said, no, I'm not a family physician. He said, are you a family physician? I said, you bet I am a family physician. I've not seen patients for a while, but I'm still a family physician. So yeah, patient volume. And as we said, the patients present to you in undifferentiated stage of the illness. This is a recipe for uncertainty. In primary care, we're not as certain as a specialist in the hospital. We don't have access to diagnostic tests. And so what we do is, we have to deal with our uncertainty. We have to live with the uncertainty. We have to be friends with uncertainty. And as I said, uncertainty, medicine is a science of uncertainty and an art of probability. You're going to see a lot of definitions of diagnostic error. But to make it as simple as possible, if a diagnosis is missed or delayed or wrong, then it's a diagnostic error. Example, a patient who comes 3 times to the clinic and with alarming symptoms but not diagnosed as colon cancer is a diagnostic error. Or if that patient himself or herself had anemia but then could not follow up, either because the primary care is not accessible or because it's very difficult to come to a primary care center or they see another physician, then it's a delayed. Or if the patient is told that it's because of your hemorrhoids, because we tend out to depend on the most common diagnosis. Does it sound okay, by the way, the quality of the sound? Okay, good. Right. So how big is diagnostic error in primary care? These percentages come only out of reported incidents, reported harms. And you know that the harm is much more than the reported harm, because we don't report everything, right? So 46% of a preventable harm are due to diagnostic errors. I was talking about 0.1% a while ago. 46%, 64% of safety incident database are diagnostic errors. 44% of patient-reported material, when patient reports an incident, are diagnostic errors. This is huge, and it's underestimated, and it's being undermanaged, and that's why the WHO is focusing this year on diagnostic error. Even the international standards like JCI have added now a complete standard for diagnostic errors, and they need you now to follow up with diagnostic error. Now, remember that diagnosis does not happen over a certain point in time. It happens over time. It's a progressive process. It starts with the patient-physician encounter, where the physician would collect information, history examination, diagnostic test, and then, of course, ask for some tests that the patient is going to perform, and then these are going to be interpreted somehow, and then you need to follow up. And this is, by the way, a breakdown could happen here, where patients don't follow up, or they follow up with a different professional, and then primary care physician might need to refer the patient to a subspecialist, and communication and coordination is a big enabler here, but it could be a big challenge as well. And of course, during that journey, the patient behavior, the patient engagement, the patient adherence to the management plan is of paramount importance in the diagnostic process. So remember that diagnosis is a progressive process. It happens over time. However, of course, a breakdown could happen anywhere, but 85, 86, I think, 84% of breakdowns in diagnoses happen in the first two steps. It's when the physician starts to collect, synthesize, and analyze information from the history, from examination, and from diagnostic tests. So, and this is what we call cognitive errors. Diagnosis depends on cognition, on cognitive power. It depends on the physician trying to put everything together, the symptoms, the signs, the result of diagnostic test, and accordingly synthesize a hypothesis of what could be wrong with the patient. And so cognitive errors is a lot, and most of the cognitive errors are related to ordering tests, interpreting tests, and collecting information, history, and examination. Now I know why the guy said they need to put a tape here, which I did not want. Okay, next time I'm going to listen to you. There are two types of biases. In making a diagnosis. One is called anchoring bias. And anchoring bias means you get anchored to something. So you think this is what's wrong with the patient. And then the more tests you do, the more information you get, you're anchoring to the same diagnosis. You don't want to change it because this was your original hypothesis, right? The other type of bias is called availability bias. It's whatever information available with you. So if you know 100 diagnoses is different than if you know a 1,000 diagnosis. So whatever is information available with you, you're gonna stick to it. I think what I'm gonna do is, because I told the guys that I don't want to, hide behind the podium, but it seems that I'm gonna hide behind. Now you know how tall I am. Yeah, this also works, right? Okay. Okay. Now you're gonna put the tape. All right. Okay. Okay. Good. All right. Do I still look handsome? All right. So availability bias, right? So remember when I said the percentages that I started with, and I said it's the reported harm by incident reporting system or the patient. In this research, they used trigger tools to identify diagnostic errors from review of medical records. It's electronic trigger tools, and I'm sure somebody is going to use the AI, by the way. And now somebody is going to talk about AI, and AI is really beating us, by the way. I was a person who says, technology or AI is never going to replace the physicians. However, when I read the research about Watson, and Watson, for those who don't know, is an IBM computer. It's a huge computer, machine learning, and they compared the precision, accuracy of diagnosis, and it beat the best physician in the world. And so it's one day, I think we're going to be replaced by robots, sort of. Although I wish it's a joke now. But anyway, right, so 190 cases where diagnostic error were identified, and most of the contributing factors were related to, again, provider. It's not sticking. Okay. Anyway, don't worry, I'm gonna be here. It's related to diet. Can you turn it? Yeah, okay, good. Yeah, so most of it is related to patient-provider encounter. And remember, it's about the collection, synthesis, analysis of the information and converting it to a diagnosis. Right, so how do physicians see diagnostic errors as opposed to how patients see diagnostic errors? Sounds.
Deal with the problem because it takes a lot of work and you're already under this huge load. So maybe it's not even because you're a bad person, but just because there's 10 rocks you're holding up, and then if you get one more, you're worried, so you punt the rock to someone else. But what ends up happening with people who have non-specific symptoms, when I say non-specific, meaning if you come in and you have AS and you have back pain and fatigue, that could be 500,000 different conditions.
Yep.
So in order to properly diagnose it takes a lot of work to do a proper history, a proper physical, to order the correct tests without over-ordering tests and all these things, have a good communication line with you. So people are like, I'll punt it.
Try some ibuprofen.
And guess what? You can't really sue them because they're like, there's back pain and I said it's musculoskeletal, is it not? And they're technically right, but they're also technically doing a disservice by doing it.
Right. The WHO has a video called What If? And I want you to see how patients perceive diagnostic errors.
You know, I live with two words, if only.
My name is Lieutenant Colonel Stephen Coffey.
My name is Kimberly Roger.
My name is Jeanette Averett.
My name is Sarah Keel.
My name is Desiree Collins Bradley.
I'm Susie Becken.
I experienced a diagnostic error.
My son, Stephen Coffey II, experienced a diagnostic error.
I experienced a diagnostic error.
My son, Chad, experienced a diagnostic error.
My 11-year-old daughter, Deance, who is medically complex, experienced a diagnosis error.
I experienced a delay in diagnosis of a serious, life-threatening sepsis caused by a routine laparoscopic hysterectomy.
His metabolic condition, galactosemia, was not fully explained to us as parents or among the military staff at the hospital.
I was told I needed to scale down my stress, so my doctor set me up with clinical massages, anger management, and even a nutritionist.
The appropriate workup for my anemia was not recommended.
When I saw the surgeon with symptoms of infection, it was not investigated and missed.
Deance went almost over a year being misdiagnosed.
And 1 week later, he had a liver transplant. What if the doctors who had told me on the phone my son had galactosemia clearly articulated the severity of his condition?
Nevertheless, I suffered a stroke a few months later at the age of 42. What if my doctor had prescribed a carotid artery examination and a full physical?
This resulted in a delay in my diagnosis of stage 2 colorectal cancer. What if appropriate diagnostic tests had been recommended and performed in a timely manner?
This delayed finding and treating an internal abscess, which in turn resulted in a massive hemorrhage and led to 2 emergency surgeries and septic shock. The impact to my family is immeasurable. What if my surgeon had done blood work or investigated my symptoms when I saw him in the office 3 weeks after my hysterectomy?
She actually had an antibiotic-resistant infection called serratia. She has permanent lung damage. My what if is, what if her primary care physician had not been in her tunnel vision of this is just a routine infection that Deance always gets, and had consulted her other specialists, and B, had ordered further testing a whole lot sooner.
Chad was misdiagnosed 3 times in 1 year. He was ultimately diagnosed with stage 4 colorectal cancer. At the age of 37, Chad died after 16 months of treatment and painful side effects. What if the proper tests were done initially for an accurate diagnosis and treatment initiated earlier, then maybe he would have survived.
What if that was one of us? What if that was one of our beloved ones? It really is happening every day, and we need to do something about it. So when we say diagnostic error, the first thing we think of is that it's the physician mistake. It's his mistake. He should have done something he didn't do, right? But when we think about diagnostic error, let's think of missed opportunity. There is something that the healthcare provider should have done, and I say healthcare provider, not the physician only, and even the patient, by the way, should have done but did not do. That's commission, or did not do but should have done. That's omission, right? So it's either there is somehow a missed opportunity. Sometimes, however, there is no missed opportunity. Despite careful analysis, there was nothing that could have been done to diagnose the patient in the right time and correctly. If there is no missed opportunity, then there's nothing to be done. And so we need to focus, when we talk about diagnostic error, on missed opportunities. When there are missed opportunities, there could be no harm, but there could be also harm. And so if there is harm, this is the area where we want to focus on, the preventable diagnostic harm. And so I'd like to redefine diagnostic error as missed opportunities that could be used to promote learning and improvement, instead of assigning blame to people and responsibilities. So the criteria to consider when you analyze and you think of diagnostic error: first, think of a missed opportunity. Is there an evidence that there was a missed opportunity? And then think of the missed opportunity in the context of evolving diagnostic process. Remember, we said diagnosis does not happen at one point, at single point of time. It happens over time. It's an evolving process. And so was there an omission or commission as appropriate to the time sequence of the diagnostic process? And then don't forget that the opportunity could be missed by the provider, who could be a physician, a nurse, or another healthcare provider, or maybe the care team, or maybe the system, and even the patient. So the detection of diagnostic error, most of the diagnostic error, by the way, 85% of cases where diagnostic error were identified, there was a different healthcare providers involved. So there's like that lack of continuity of care with the same healthcare provider. In around more than half of the patients, the diagnostic error was detected due to failure of the original symptom to resolve. In around one-third, more than one-third, detected when a new symptom has been developed, evolution of the same symptoms, and 22% when new symptoms have been developed. And so it's really detected basically when something happens, when there is some sort of progression. Most common symptoms are cough for diagnostic error, pain, shortness of breath, or maybe asymptomatic, just part of a routine visit. Look at this. These are the most common symptoms that present to primary care. And these are the symptoms that most commonly are associated with diagnostic error. Most diagnoses that are missed include cancer, colon and skin, renal diseases like UTI and acute renal failure, MI, heart diseases in general, fractures and pneumonia. Unfortunately, diagnostic error is not harm-free. It's mostly harmful. Most of the patients have considerable harm and even immediate or inevitable death. So it's not a trivial event. When there is a diagnostic error, most likely there will be harm. So let's sum it up now. The diagnostic errors, the factors contributing to it. We talked about the access, lack of availability, the shortage of primary care physicians and other healthcare providers as well. The limited access to specialists is a factor as well. Diagnostic tests, we can't, in primary care, we don't have access to all diagnostic tests. We can't do CT and MRI if we want to. There are lots of restrictions over that. Apparently, it's building a wall here. Communication is an issue, whether between the care team in primary care or between the primary care and the secondary care, the specialists, the hospital. Care coordination, when there are multiple care team members, then coordination is of paramount importance, of course. Lack of follow-up or follow-up with a different healthcare provider is an issue. Our healthcare providers need to be trained. Availability of health information system, we were saying that the technology now can help a lot, and we still see a lot of our primary care with paper medical records. Affordability of care, especially when for those who don't have access to free care, the culture, the blameful culture, and the human factors. In primary care, there is a lot of distraction because of the patient volume. And how are we going to destroy that wall? Again, a BMJ article back in 2017 suggested some potential interventions, very good interventions. For the sake of time, I'm going to go quickly over them. But it starts with improving diagnostic reasoning among physicians. What we do is, you know how many times the primary care physician see a patient with cough? Why would he think that this could be a lung cancer? Cough is upper respiratory tract infection, right? And so we want to encourage our physicians to reflect, because once the thinking goes to the subconscious, to the cerebellum, the availability bias, the easiest diagnosis, the most common diagnosis come in mind, and then we anchor to it, we fix it, and we try to prove it by any means. Reflection is a very good practice. Encouraging government policies to support primary care. Patients should act as the safety net. Our patients are very passive healthcare receiver. They are not active. They wouldn't question you. We have that paternalistic relationship with our patients where they think we know the best. Primary care physician, my colleagues know that if we ask the patients about their expectations or concerns, they say, "You're the doctor. I'm not the doctor. Tell me what to do." And so encouraging patient to be the safety net is important. That's involving the patients. The government policies, specifically in the low and medium income countries, is important. The improving access to primary care, improving information technology, and we talked about that. The machine can help us a lot. We don't need to think. We don't need to use all of our cognitive power if we have someone, and by someone I mean the AI, can help us. Developing methods to identify and learn from diagnostic errors, again, improving the culture of safety would improve the reporting, and that would improve the learning process. If we don't learn, if we don't report, we don't analyze, we don't learn. If we don't learn, we are an organization without a memory. We are a dementic organization that would do the same mistake again and again. Optimizing diagnostic strategies in primary care, including the use of tools, trigger tools, in the electronic medical record, and providing systemic feedback. Closing that loop is important. We refer patients as primary care physicians to the specialist, we never get news back. We don't know what happened to the patients. We don't know if we did good or bad. And so closing that loop is important. Conclusion, diagnostic errors are preventable. They can be reduced by improved clinical reasoning, better communication, and some systemic changes. And we definitely need ongoing training, collaboration, and use of decision support tools. These are the references that I used. Thank you very much. It was nice to have you. Thank you.